Hello. Can you hear me? Yeah, good. Wonderful. So my name is Ulrike Brandenburg. I'm a neonatologist by trade, working at Nepean Hospital in Sydney, New South Wales. And I was going to talk to you today about neonatal resuscitation. I think one of the things which you may encounter throughout your work, but maybe not very frequently. So hopefully I can leave you with a few sort of things to remember if you ever get into the situation to needing to look after a baby who has some struggles after birth. So, you know, when a baby is born, it's actually a quite significant transition for this little human being, because it sort of starts from being a fetus, living in water, depending on the placenta, to suddenly come out and be quite sort of self-sufficient with breathing and oxygen exchange. So it's quite a miracle how this happens so often, actually, without any trouble. But sometimes this isn't so straightforward, and some babies do get into trouble after birth. And often it is very, very simple interventions we can do to help them overcome this trouble. And often those simple interventions prevent this baby to become even worse or even to die. And it's good to know what to do when you encounter a baby who is in trouble. Very few infants actually require what we would call full resuscitation, as in, you know, CPR and adrenaline and so on. So this is the data from the Australian Institute of Health in 2017. And you can see about 7 to 8% of babies require some suction, some airway management of some sort. About another 7% require some positive pressure ventilation via mask. And only very, very few actually require full CPR when they get into trouble. And this sort of reflects actually the sort of causes as to why babies get into trouble. And this also reflects what you can do when a baby is struggling after birth. Now, I promise there will be no more physiology in this talk, but it is really important to actually know a little bit about the difference from the fetus as opposed to the neonate, and why those few interventions we can do for resuscitation are so important, what actually makes them so successful. So here you can see this is a circulation in the fetus. This is what it looks like before birth. You have the placenta here. From the placenta you have the umbilical vein getting all the oxygenated blood and all the nutrients and everything, but let's talk about the oxygen at the moment, right into the inferior vena cava, and then from there into the right atrium. From the right atrium, there is a little flap. It's the foraminal valley, where the blood crosses into the left atrium. So the flap sits here. The pressure is very high in the right side of the heart in the fetus, so it easily crosses over, and then from the left atrium goes into the left ventricle, and from there into the aorta, into the body, and brings whatever is left on the in the oxygen way into the body. There's obviously some blood which goes from the right atrium into the right ventricle and into the pulmonary arteries, because the lungs are needing some blood as well to grow and develop. But there's obviously no gas exchange in the lungs, and a lot of that blood which goes into the pulmonary artery actually crosses via the ductus arteriosus into the aorta. So after birth, this circulation changes into the neonatal or adult type of circulation. And I wonder whether anyone sort of is keen to have a go at what would be the one action, the one change after birth initiating the whole change of the circulation. Does anyone have an idea? Breathing. This is really good. I'll leave it at that. So the one change which has to happen for this circulation to change is actually the lungs to open up. Doesn't work. So when the lungs open up, the breath in, what happens is that all those little capillaries around the alveoli start to expand, because the alveoli, from sort of a little sort of squashed down sac, suddenly gets really big, and the arteries around, the vessels around that expand, and there's a lot of blood which can go in there. So what happens is that a lot of blood suddenly disappears into the lungs, so the pressure in the right ventricular system suddenly drops significantly. Yes?
Can't hear you very well.
Oh, sorry. So the pressure in the right ventricular system drops significantly by taking that first breath, by opening up all the alveoli. And when that happens, then all the rest of the changes of the circulation start happening. The foramen ovale starts closing, because the pressure in the left ventricle, left atrium is now higher than in the left and then in the right atrium. The ductus arteriosus is slowly kind of closing down, but what happens is that the shunt in the ductus arteriosus start to change from left to right, rather than from the right pulmonary artery into the aorta, which is left. And when that happens, all the oxygenated blood then goes into the body and into the organs, and that's how we have the neonatal circulation. So really what needs to happen for the change of the afterbirth circulation is that first breath, the opening of the lungs. Now, the cutting of the cord has, in a way, nothing to do with that change of circulation. But the timing of the cord clamping and cord cutting has now become part of the neonatal resuscitation guideline. Why is that? Because when there is some trouble with this transition, when there is trouble opening up the lungs, when it takes a little bit longer, then through the cord, the placenta is still providing that little body with oxygen and nutrients. So remember, the placenta, the umbilical cord is going to be your friend. I know it says here, you know, cut after a minute or cut after 1 to 3 minutes, but really don't cut the cord, because it is going to support that little body if you have any trouble opening up those lungs. So I've certainly encountered very extreme premature babies whose cord weren't cut like for about 10 minutes, where there was trouble opening up the lungs. And these babies have just done fine, because the placenta just did its job. Yeah, it's not gonna be helpful when the placenta is born. Obviously, there will be some end to it, but a lot of time it works for many, many, many minutes. And it's not only that, you know, it sounds like a good idea or it makes physiological sense. There's also good studies now showing that the outcome of extreme premature babies, of neonates born with severe hypoxia, is much better if they get resuscitated whilst the cord is still unclamped and whilst they're still attached to the placenta, with a significant change in their mortality. So this is something to take away. Do not cut the cord if you can help it whilst you're looking after a baby who has trouble making transition. Yeah, so there is some studies which show that milking of the cord potentially increase some risk in brain bleeds, probably related to the very sudden change of pressure you're kind of getting when you suddenly have a high influx of blood. So if you had to cut the cord because I guess you have to move the baby away from, you know, where the baby is. It's not everyone's sort of desire to do a resuscitation in between maternal legs, I suppose. So if you had to move the baby away and you have to cut the cord for that, it is a possibility that you do some sort of slow stroking and slow milking. The evidence is a bit sort of, yeah, a lot of people still do it. Some people say it shouldn't be done, but I don't think that the evidence is so clear. So this is the newborn life support flowchart. This is on the resus.org.au website, and I suggest to have a flowchart like this around wherever you potentially encounter the resuscitation of a newborn baby, just because it's really helpful to be able to look up what's the next step. If you have it there and you know the chart well, it is quite easy to find the answer if you have a question during the resuscitation. This is the flowchart's first minute, and the first minute is really, really important. Because what ideally you want to have happen is that the opening of the lung starts within the first minute. So for that, a few things have to happen during that first minute. So you want to obviously have assessed the situation, whether you have a baby who is breathing, or what the tone is of the baby. And that gives you a bit of an idea of whether this baby needs any form of resuscitation or help, and whether this baby is struggling with the transition. The tone, the muscle tone, is actually a really, really good symptom for you to observe after birth, and it's also quite a good, quite an easy symptom to pick up. So if you have a term infant being born, generally what happens, because they're actually squashed down in their little fetal position in the room for a few weeks, they've been quite tight there. What happens is that when they're born and they're out, they sort of immediately move sort of back into that fetal position. They bend their arms and legs, but they can only do that when they have a good muscle tone. So if you have a baby who's kind of come out and is sort of not really moving arms and legs well back into the fetal position, then there is something problematic with the muscle tone, and that's often the first sign that this baby has been struggling and is potentially at risk of trouble during the transition. And then obviously the breathing, you would need the baby breathing to start the change of the circulation. Most babies cry, but you know, not all of them do, so just a big breath and breathing is just fine. So if you have a baby where any of these questions is no, you really want to look after them appropriate, look after their airway, make sure they have an open airway, that it's not obstructed, and you want to make sure that if they don't breathe, or if they have a really low heart rate, that you start the positive pressure ventilation, that you start opening up the lungs for them. And ideally, you do all of that whilst the cord is still attached. And I know that is practically sometimes a bit of a problem, but that would be the ideal situation. The Americans call this also the golden minutes. I guess they like those sort of lovely terms. In this golden minute, you want to start the assessment, and you want to start the monitoring. Obviously, monitoring, you know, we do sort of, we see and we touch, and stethoscope is the probably main equipment to use to start with the monitoring and assessment. But the other devices which are really important are ECG monitoring and saturation monitoring. If most of you working in emergency care and emergency departments and as paramedics, you'd be quite used to ECG monitoring, which is less so the way for actually neonatal people. We're not so used to ECG monitoring, but we're embracing it now. So it's a really good idea to put your ECG leads on to get an idea about what the actual heart rate of this baby is, because it is sometimes very difficult to hear with the stethoscope, especially if there is like lots of other noise around. It's important to remember though that the ECG gives you the heart rate but not the cardiac output, so it's really only one way of checking how well this baby is. And also to know what the normal heart rate of a newly born baby is. So an ECG can look just perfect with no sort of signs of problems at a rate of 55, but for a neonatologist that means the baby is dying. So it's really important to know that what you aim for is actually a heart rate of above 100. And anything below 100 in that first few minutes after birth is a big, big alarm bell. And anything below 60 requires CPR. So you don't really want to get there. So this is really important that when you do ECG monitoring, look at the rate. That's the important thing, not so much at all those zigzags, which I have not much idea about. So the pulse oximeter is something we use quite frequently, and I'm not sure what that sometimes looks like when you attend an emergency situation outside the hospital. It might be not something you have available straight away. It is important to recognize that saturation monitoring requires somewhat a perfusion of the limb where you put the saturation monitor up. So if you have not a good perfusion because there is not great cardiac output, then you wouldn't have a good number. And unfortunately, most of those saturation monitors, they don't really say not possible to monitor. They just give you some random number. So it's really important that you just take it with a grain of salt, and only after establishing really good perfusion or somewhat good perfusion are those numbers in any way reliable. The other important thing to remember is that if you remember the fetal and the neonatal circulation, to really capture also incidents which happen like in the middle of the transition, you need to put the saturation probe onto the right hand. Why is that? Because if the transition hasn't happened properly yet, so if there is still some form of fetal circulation happening and the blood flow through the ductus arteriosus is going from left to right instead of right to left, what you get is that after the ductus arteriosus enters the aorta, everything is potentially a much, much lower saturation because you have now less oxygenated blood flowing into the aorta and mixing there. So that can potentially be, is often the left arm. It's definitely both the legs. So only the blood supply for the right arm is going off the aorta before the ductus arteriosus enters the aorta. So always put your saturation probe onto the right hand and don't try targeting saturations which you measure on the foot. That is really, really important. So in this golden minute, we said after stimulation is important, you know, because some babies, what happen is that they had a bit of a strugglesome birth and they're just stunned. They, let's call it, forget to breathe, even though that's a bit stupid. They don't forget to breathe, but they're just not having taken that first breath yet. And sometimes all they need is a bit of stimulation. You know, it's like in those old movies when you see a baby being born and the doctor picks the baby up by the feet and gives it a slap on the bottom, right? This is what this is for, only that we do not slap children anymore, yeah? Anywhere, so not the bottom, not the feet, all the slapping has gone out of the recommendations. So stimulation is easy, just rub the back. You often have towels to dry the baby, sort of a bit of rubbing. That is all which is required if the baby only needs some stimulation. If the baby is in deeper trouble, then stimulation wouldn't make it breathe. But certainly it's worthwhile giving it a go and stimulating first. And then we should start ventilation if this baby is not breathing and if the heart rate is below 100. That's really important so that we get that transitioning of the circulation happening. Now, what does ventilation do? So ventilation, obviously, it opens up those alveoli, it opens up those lungs. It helps clear the fluids across the lung tissue, and it helps to establish adequate functional residual capacity. And when a baby is adequately ventilated, when this is all happening and you get the change in the circulation, then the heart will get enough oxygenated blood to increase the heart rate. Remember, our neonates, when they're born, they generally have the healthiest hearts you will ever find. So the majority of your patients, I assume, have some problems with their hearts. Well, I tell you, babies generally don't. Their heart is the most mature organ they're born with and the strongest muscle they have, and it's generally really healthy, you know, with some exceptions. There's obviously babies who've been so hypoxiated or who've got some cardiac abnormalities, but that's quite rare. So generally the heart is not the problem, it just needs a bit of oxygen, needs the ventilation to go appropriate, and so that it gets enough oxygen to start beating again. And it will if you provide sufficient ventilation. If you start cardiac compressions on these babies before you establish the ventilation, this can be quite detrimental. Because imagine this is just a little body, so if you squeeze down and you have to do cardiac compressions properly, you often interfere with good ventilation. So you really want to open up those lungs before you potentially start some compressions. And you need to give it a few minutes. Most babies, if you have really good ventilation, will not need cardiac compressions. So all you need to do is ventilating when the baby's not breathing, and that'll get you through the day. So what is ventilation? Ventilation is airway plus breathing, yes? So you need to have a look and make sure that the airway is clear. The baby might need some suctioning, especially if there is some meconium around. Some babies, if they do have trouble during the birthing process, they start passing the first stool, and they might have some meconiums in their airways. So you want to give it a really good suction before you start ventilating. But no other actions. So just get the head in a neutral position, suction, Just remember that there's been some old guidelines suggesting intubation to remove meconium that's long gone. That is sort of impossible, and now it's reached the guidelines that it's actually impossible and detrimental to do. Important is to really have a good neutral position of the head, and I get to that a little bit later. And the mask is an appropriate size, covering the mouth and the nose. So we're always covering both, but it needs to be appropriate enough to not cover the eyes, because you don't want to put pressure on the eyeballs and get some vagal reflex. So that's really important. And the best way to check whether you appropriately ventilate is that you get some rise and fall of the chest when you ventilate, to know that you're doing a good job there. The other symptom you get when you appropriate ventilate is actually that your heart rate increases. So this is a really, really good sign that you're ventilating well. So give it those minute or two of really good ventilation, and you will see that your heart rate is coming up. You will eventually also see an improvement of the oxygenation, but that is usually a little later. So for ventilation, we generally use a device called Neopuff. It's a T-piece device which allows us to set a PEEP, a PIP, a maximum inspiratory pressure, and a flow. I would assume that most of you are really familiar with the use of a self-inflating bag or ladle bag. This is our backup device because a self-inflating bag is independent from gas flow. So this is a really important device to have if you don't want to sort of have issues running out of gas. I guess the recommendation is to use a T-piece device for ventilation, or something like the anesthetic bag, where you can set a positive end expiratory pressure, a PEEP, as well as just giving the inspiratory pressure, which the ladle bag, at least the neonatal devices, usually don't have any PEEP valves, don't have any well-functioning PEEP valves. So with the PEEP, it is really sort of easy to help maintain that functional residual capacity, because you don't want to sort of give a lot of pressure to get those lungs open up, and then when you have the expiration, they collapse again. And you know, they're all filled with, you know, water, with amniotic fluid, right? So when they collapse, they stick together. It's actually hard to opening them up. So sometimes you need quite high pressures. So with the PEEP, it helps you to keep them inflated, to maintain the functional residual capacity. And that helps to improve the oxygenation much quicker than you'd be able to do that ventilating without a PEEP. The recommendation is to use a PEEP of between 5 and 8 centimeter water. And there are recommendations about the rest of the settings in the neonatal resuscitation guidelines. Generally, we suggest to start with a PEEP of 5, inspiratory pressure of 25, and have the flow set between 8 and 10. But that can be slightly different between different areas or different policies. So I suggest you have a look at what your policy and recommendations are in the area you're working at, so that you're familiar with what the initial settings are. Now, oxygen. What do we do with oxygen? How much oxygen are we using for the initial resuscitation? Anyone a guess? Yes, so we definitely don't use 100%, because we know that 100% oxygen is really detrimental. I mean, not only has it a lot of issues in regards to, you know, free radicals and work of breathing. But actually, we also know that the use of 100% oxygen is increasing the mortality of the infant you resuscitate. So it is really important to not use 100% oxygen, at least to start off with, to minimize morbidity and mortality. Anyone knows who this is? Yes, Stevie Wonder. Do you know why he's blind? He had retinopathy of prematurity. This is an eye disease which develops in nowadays extremely low birth weight infants associated with oxygen delivery. But obviously he was born a long time ago, and he was a 35-weeker. But that just shows you at the time the use of 100% oxygen was very, very common because that helped them to get those babies with severe lung disease to survive. And only later was found out that it actually caused a lot of harm. So the recommendation is to start with 21%, start with air. That's why it's really important that wherever you anticipate resuscitation of a newborn infant, you have some air source. Because obviously you need some oxygen as a backup in case you actually need oxygen, but it is very important to have air available as a gas when you attempt the resuscitation of a newborn infant. So the 100% oxygen we really only use for this baby who requires CPR and adrenaline. So the ones where, you know, you really want to get every oxygen molecule into possible. Oxygen you then target depending on the saturation limits. We know that newborn infants don't increase their saturation to like 99 straight away, right? So they're not like little adults. It takes some time. And this is a suggested target range done on some healthy newborn population. So you can see that 60 to 70 at 1 minute would be completely fine because that's actually what the saturation of a fetus is inside the womb. And then slowly in the first 10 minutes or so, it increases up to 90%. That's all they need in the first few minutes. Remember, they all have the fetal hemoglobin. They have, you know, really amazing ability to use those oxygen molecules and, you know, drop it and pick it up in the right moment. So they do not need, actually, they should not have a saturation of 99 or 100% unless they do that all on their own without our interference. So if the heart rate is not improving with positive pressure ventilation, and that's kind of highlighted on the flow chart as well, you don't jump onto the heart. You really start again from step one. You really try to improve your ventilation. Remember to increase the peak inspiratory pressure. A lot of babies need very high pressures to open up those lungs. Just for a few breaths, you need to come right down once you have the chest movement, but a lot of them, 25 or 30, is not enough to open up those lungs. They sometimes need 40, 45 before you're able to open up the lungs, and then you kind of come right down with the pressures. And then there is always the question, is this enough? Do I need any sort of form of intubation or so instead of the mask ventilation to improve the ventilation? So it's tricky because the neonatal airway, again, is not like a small adult. It's actually very different. So it's important to remember that there's a few things which would be very important to acknowledge, which can improve your mask ventilation, but which also may affect your ability to intubate. So the mouth is relatively small with a relatively large tongue in there. You also have a quite floppy epiglottis, which is sort of shaped a bit like a horseshoe, so very different shape to an adult. there is often quite a large occiput, which kind of tends to be problematic with a good positioning of your head. And you have a relatively large anterior larynx. And this is one of the big problems, because when your larynx is already sitting quite anterior and you start bending back the head, because, you know, let's be honest, that is what you've been taught from the get-go, because that's how you ventilate adults, right? You sort of stretch the head so that you have a really nice air entry there. For neonates, that is detrimental because it moves the larynx even more anterior, and when that happens, you close off the trachea, and then all your ventilation efforts go down into the stomach. So this is one of the important things to check. Do you have the head actually in a neutral position? Because the moment you bend their head just that tiny bit too much, you close off the trachea. But that also means that you need this really perfect position when you try to intubate. And additionally to that, your trachea and epiglottis look really, really different. So you can see that's the epiglottis of and vocal cords of an infant. So that isn't even a neonate. It's a bit worse than a neonate. So the vocal cords are not necessarily these nice white bands, you know, and you have like a really good sort of location there to put your ET tube in. So it is actually quite difficult. This is a brilliant view here. You not always get this view. You only always, like, sometimes get sort of half this view. So it's tricky, and I wouldn't recommend a go at an intubation in a baby who's already sort of compromised and who you can't ventilate. I'd rather go with improving mask ventilation, and that might actually mean to use an LMA. So LMAs are really perfect, and actually you probably know better than I do, because it has taken forever for LMAs to come into neonatal care. And I believe you all would probably use them quite widely in emergency care. And they're certainly really good devices to use, and they're also getting better in view of targeting certain size of our population. So we do now have size 0 LMAs available, which you could use for even preterm infants as small as 1.5 kilo or so, which for a long time this just wasn't available. But this is a good device to have, and certainly I would recommend to use that if there is issues with the mask ventilation.
When you come to a situation that you want to intubate, do you use any muscle relaxers, or you are holding it?
Yeah, so when I talk about the neonatal resuscitation after birth, you do not have IV access. So we kind of have the IV access here, but what you need first is a stable airway. You don't go for the IV access first. So no, you don't give any medications because you have no way to give them. Again, they are compromised. They're not breathing. They're not moving. Yeah. So otherwise, you don't need to intubate. But if they have some form of respiratory effort, you usually don't have issues with the heart rate, and all they need is just appropriate respiratory support. But if they are so compromised that they're not breathing and their heart rate is so low that they require CPR or a improvement of your ventilation efforts, then you would just try. So I definitely go for the LMA before the intubation, just because the time it takes you to put an ET tube in, this is a time where the baby is not ventilated, okay? But what this baby needs is actually ventilation. So that is very tricky to do. If it takes you a minute to get an ET in, then that's a minute of no ventilation at all. So that's a very tricky situation to be in. Now, IV access. So obviously, if the circulation is compromised, if there is no cardiac output or the heart rate is less than 60 despite good ventilations or lots of effort to provide good ventilation, you do need to look at your circulation. So when you start to decide that this baby needs chest compressions because the heart rate is just not improving, that is the time that you know you will need IV access. Because chest compressions, we just talked about, you know, the healthy heart. If the heart doesn't improve with ventilation, it's not going to improve with chest compressions. So this heart will need some adrenaline to get going, so that you have to give via IV access. So when we start the chest compressions, we deliver with the two-thumb technique. Rather than just a finger or 2 fingers or so, it's shown to be much more effective. You hold the infant's chest in your hands, and with both the thumbs, you do compressions. And same as an adult, 1/3 of a depth of the thorax, looking for the good position. If you have an imaginary line between the nipples and here the xiphoid, it's right in between where you want to have your thumbs for the chest compressions. Starting chest compressions, though, means you need to prepare for IV access. The rate, I should mention actually, the rate of chest compressions in a neonate is 1 to 3. So 1 breath, 3 compressions, and you stop for the breath. And this is just reflecting how important the ventilation is. It's not going to be any less important just because you started CPR, but it's really important that you have that short stop for the breath, so that there is the possibility for the lungs to inflate during the compressions. And then we would try to give adrenaline. So IV access, because you can, if you have an ET tube, you could give the adrenaline down the ET tube, but it's not shown in research to be very effective. It's just kind of a bit desperation. It should not delay your trial of IV access and giving the adrenaline IV. That's really important. So how do we do IV access? Well, my patients get born with their easy central venous access, okay? So there is no trouble whatsoever to get a central line in minutes. So that is that's a very lucky situation to be in, but the umbilical cord is just there. And it is very straightforward to put a catheter into the umbilical vein. Much more straightforward than an interosseous, which is the second option, and much more straightforward than placing an IV cannula in a baby who's not perfused. It's hard actually in a baby who's well perfused, I tell you, so it's impossible to put a cannula in when you have no perfusion. So with the cords, the umbilical cords, I assume like people know what an umbilical cord looks like, but to me it sort of looks a bit like a face. Don't know whether you agree. So there's 2 eyes here, and then there's a mouth, all right? So the 2 eyes are the arteries. So the 2 eyes is like sticky out sort of little vessels. They look like spaghettis sticking out of the cord, okay? Even though in reality they're actually macaronis, because obviously they have a lumen, right? But the lumen you don't see because of the muscular wall, the arteries constrict. So it is very hard to get a catheter into the artery. So you shouldn't worry about accidentally putting it into an artery, because it's actually really difficult. The mouth here, on the other hand, is the umbilical vein. That's where you want to put the catheter in, and that's actually really easy because there's no muscular wall. The the umbilical vein is quite floppy and quite easily sort of to access with a catheter. The one thing you need to remember is before you cut the cord to put your, you know, when the baby's born, gets the cord clamp on, obviously, otherwise it's going to bleed out, right? But to put a catheter into the umbilical vein, you need to cut the cord clamp off because otherwise you can't access the umbilical vein. You need to put some band around the base of the umbi because otherwise, if you cut the cord, the baby's going to bleed out, especially if someone is on the chest doing effective CPR. You get splashed with blood every time there's an effective compression of the heart. So you put a cord tie around the base of the cord, and then you get your catheter into the umbilical vein. It's actually, when you put the cord tie and then you cut the cord, there is still like a tiny bit of blood left in that part of the umbilical vein. So if you cut the cord, you see that little drop of blood coming out of the mouth, like, you know, like a tongue poking out at you. It's like, so that is the spot where you want to go. So if you see that blood coming up, this is where the umbilical vein entry is, and this is where to go. It's really straightforward. You have to believe me. Drugs in neonatal resuscitation is really easy. So we are not complicated at all. There is not that many. In fact, there's actually only one. It is adrenaline. So when we give adrenaline, just to remember, we give 1 to 10,000. You don't want to overdose the baby. So if there should be 1 to 10,000 ampules available everywhere where there is a potential risk of a delivery of a baby. But if you are, I don't know, in an ambulance, or I don't know what you carry, you probably don't carry 100,000 of different drugs. You might only have the 1 to 1,000. You need to dilute that down. Yeah? So you put it into a 10 ml syringe with sterile water or normal saline or something, so that you have a ml of the 1 to 1,000 and 9 mils of the normal saline, so that you have your adrenaline in 1 to 10,000. And then you give about a ml, all right, in the term baby, about half a ml in the preterm baby, because obviously we like to have always the decimal points and the calculation. You know, we do everything in at least 2 decimal points. But because we haven't weighed this baby yet, because remember, we're still resuscitating, it's a bit pointless anyway, because you need to guess the weight, okay? So a ml a term baby, half a ml a preterm baby. And then you can repeat that after a few minutes if it is not sufficient. But it does take a few minutes of effective CPR to get that adrenaline around the little body. And the other thing we use is volume expansion, and that's because sometimes the reason for a baby to be unwell after birth is blood loss. And sometimes this is tricky because you may not see the blood loss. It might be blood loss because there was a placental vessel, which was a fetal vessel, ripped from the placenta before birth. That's hard to see because there is blood around deliveries anyway. Sometimes that is a fetal maternal hemorrhage, where the baby hemorrhages into the circulation of the mother via the placenta. So there is kind of reasons for blood loss. If you do expect that there is blood loss, you would give normal saline as an initial volume and get O-negative red cells up as soon as possible to give blood. And a really important thing in neonatal resuscitation is to remember looking at the temperature. Because the temperature can have a big impact on the baby's morbidity and mortality. So what this means for term babies, if the baby is generally well resuscitated and there is no risk of hypoxia or asphyxia, you want this baby in a normal temperature. You don't want this baby to get cold. If you have a baby who's had severe hypoxia or oxygen deprivation, you might want this baby a little bit on the cold side, and certainly you don't want it too hot. If you have a baby who is very premature and of very low weight, you definitely don't want this baby to be cold. And it's very difficult to keep those babies warm because preterm babies, they have not sufficient brown fat. They have a huge skin surface, which is immature skin, which loses heat really, really quickly. Especially their head is really big. So you need to put a hat on, make sure you keep the baby warm. How do you keep the baby warm best? In lack of, equipment on mom's chest, between her naked breasts, okay? Really good incubator for a while. So if that's all you have, that's a good thing to have. So a preterm baby, put on the mom's chest until you have something to put the baby into. And the biggest thing, remember to check the temperature. It should just be one of the things, like you check a blood pressure or you check the heart rate. You need to check the temperature in a newborn baby. This is really, really important. Especially for babies less than 1.5 kilo. We know that for every degree less than 36.5 this baby cools down to, the mortality increases by almost a third. So temperature is really important. And then there is other important things. If a baby needs significant resuscitation, you do not get this baby back to the mom and discharge her early. This baby needs some monitoring, some special care to observe for acidosis, hypoglycemia. So it's really important to provide appropriate post-resuscitation care. And also remember the family. This is important because, birth is meant to be this all-natural, wonderful situation where, the family grows. Women often have birth plans, and they often don't go really that well. And when things go wrong, the family is devastated. And it is very difficult for them to watch the resuscitation of their newly born infant, because that's certainly not what they expected to happen. And it's important to also not, support them, reassure them, but not to overly be positive if things are not positive. Because it's very hard if someone sits with the family and says, they're doing great, everything is gonna be fine, you'll see, and then someone walks over and says, I'm sorry, we couldn't save your baby, right? This shouldn't happen. So someone who supports the family without any promises of an outcome, just guiding them through, explaining what's happening, that's really, really important. That's it. So if there's any questions, I'm happy to answer. Yes?
What size catheter do you put in the umbi vein? And if you have already clamped it, then you decide you need to cannulate, do you just work with that, or do you then put a tight base and then do the catheter?
Yes. So the catheter size is generally a 5 French. But you can use a 3.5 or 4 French as well, generally not bigger than 5. When you have, generally the cord would be clamped because the obstetrician, midwife, whoever delivers the baby would clamp the cord prior to cutting. So you always get a clamped cord. So you then put the umbi tie at the base, and then with a scalpel, cut the umbi about 1 to 2 centimeters above the baby's skin. that's the best position to be able to still hold the umbi with your other hand, so you have like, you know, some way of stabilizing the umbi, but not too long so that you don't get lots of curls, you know, like those telephone sort of curls. So because that's difficult then for the catheter to move around too.
So just thinking about practicalities of that delayed clamping of the cord if pretty much the baby is not breathing. So, for example, our clients with resuscitation plan in the hospital is that we have one of those neonatal resuscitation, which is an integrated neopop and everything else. So the whole thing is quite big. So even if you put that next to mother's bed, it's not going to reach.
No, it's not going to reach, I agree. So, yeah.
What would be your pretty much tips around where to do it, how to do it, because the baby ends up being next to the mother, as in emotionally and logistics and all of that?
So it depends a little bit on the expertise of the team and who's going to be there to, you know, straight away to help and, you know, help stabilize the baby. So I would suggest to leave the cords unclamped as long as possible. But if you move the baby to a different spot, like a resuscitator, you've got to clamp and cut the cord. There is no other way. Oh, there is, because there is now equipment which actually moves over the mother's abdomen, and you actually be able, it's like a resuscitator which kind of sits above the maternal abdomen. So these things exist, but they're not really sort of in common use yet. Yeah, so they're a bit like fancy equipment, which is really expensive but exciting. But you know, this is not really something you would have available. So if you need a baby on the resuscitator, then you need to clamp and cut the cord. I would suggest though, if you are a midwife, a emergency physician, a paramedic, where you are hoping for someone to give you a hand in a few minutes, but you not quite have the people there to know exactly what is the best thing to do. It's probably not a big thing to take your self-inflating bag to the baby and start ventilating the baby attached to the cord. Yeah, on the mother's abdomen or between her legs or wherever that's possible. If that's sort of your environment, you'll be better off to start your resuscitation efforts with the cord attached, because it's going to help you. If you are really have high expertise in neonatal resuscitation, it's probably less of an issue. So if you're a pediatrician or a neonatologist or you know, or an ED physician who's done lots of resuscitations in newborn infants, then it may not make that much a difference that you clamp early, get the baby over to the resuscitator. That might be the better situation in that way. Yeah.
So maybe just a bit pedantic question, but if you're using the delayed clamping, when does your APGAR score start? At the delivery or once you cut the cord?
Always at the delivery, actually. I mean, you know, APGAR scores really, they were developed long before modern neonatal care, right? And they were actually developed with the intention to get a physician with expertise in neonatal resuscitation to the baby. So this is very different now, because you do have generally people who are, and that might be an experienced midwife, but you have people who are experienced in neonatal resuscitation with a neonate, especially if the baby is in trouble, because often you know beforehand, you call for the team, you know, when your CDG goes bad, right? So there's often situations where the APGAR score is like given retrospectively anyway, because it doesn't anymore determine what we do. It is more a retrospective view of how well we've done, I guess. But the 1 minute APGAR is still the 1 minute UPGA from the time of birth. And nowadays it often reflects the time actually when the baby sort of comes over to the resuscitator because of the delayed cord clamping, which is interesting. I think we have much better 1 minute UPGAs now that people are actually not able to get their hands in and do a lot of detrimental things to this baby while it's still transitioning.
Given that some of the mothers stay at home on opioid dependence or opioid medication, what's the role of naloxone if the baby comes from floppy?
Yeah.
What's the role of naloxone?
So we, the recommendation is not to use naloxone unless you're 100% certain that this mother is not opiate dependent. Because you can initiate really bad neonatal seizures if that's the case. So if you're not sure, then I wouldn't use naloxone. If you are very, very sure and say you have trouble with the ventilation, then you could just again say to the mother, you're sure you don't, because if I give this medication to your baby, then, it's going to be really bad if you had a kind of. So you can, in that moment, you can, I guess, ascertain that she's not, an opiate-dependent woman. But see, this is only a problem if you have a problem with ventilation. Generally, babies who struggle because the mom just had a morphine dose given by the anesthetist, and they don't breathe because they're a bit opiate overloaded at the time. They're often easy to ventilate because they don't have any other struggles other than not really wanting to breathe because they have so much morphine on board. So often they are easy to ventilate, they have a normal heart rate, they have stable circulation. So you just let them wake up, I guess, while you ventilate them. There is not really a need to give naloxone. The reason I can think of giving naloxone is often when you have cesarean sections and something like remifentanil also was used prior because, remifentanil is this wonder drug which goes immediately out of the system. Well, it doesn't in a fetus. It hangs around forever, and it also causes actually really bad vocal cord like they get really stiff, yeah? So it's sometimes really difficult to ventilate those babies because they're so stiff from the fentanyl. They get this rigidity. And these babies do benefit from naloxone.
All right, unfortunately we have run out of time. Let's have a nice big round of applause for Ulrike. Ulrike will be presenting for us tomorrow morning, so a great